speaking. So we have a little video problem, but the audio is working and the presentation is working, so we're going to go forward without the video. You won't be missing anything if you're not looking at me. This morning we're going to talk about warfarin sensitivity genotyping. We're going to focus on the clinical need, how to use this kind of testing, and how to interpret this kind of testing. So here's a picture of me. You can substitute that for the video if you feel you need to look at a picture. I'm a professor of arterial medicine in the Department of Arterial Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. Disclosures, I have no relevant relationships with industry at this time, and I will not be making any reference to off-label usages of pharmaceuticals or instruments during the presentation that are not already FDA approved. The main objectives for today. We're going to discuss the clinical choices for long-term anticoagulation therapy. We're going to recognize the clinical circumstances when warfarin sensitivity genotyping will benefit patient care. And we're going to review and interpret warfarin sensitivity genotype test results. Let's talk first about anticoagulants in use in the United States in 2013. First of all, physicians regularly use a low molecular weight heparin, Rivaroxaban. That's an intravenous only option and is short-term therapy. Within the category of vitamin K antagonists, warfarin is the only drug on the market today. Within the category of anticoagulant agents, clopidogrel, known as Plavix, and prasugrel, known as Efficient, are available. Within the category of factor Xa inhibitors, there's Rivaroxaban, known as Xarelto. That is the only factor Xa inhibitor available today. And then among the thrombin inhibitors, there's dabigatrin, known as Pradaxa, and argatroban, that is for IV use only. Let me stop here. I forgot to say something at the beginning because we weren't connected by video. We do have a Q&A session going, so if you notice on your screen, there should be, I believe it's a green button. If you want to ask a question, please go ahead and do so, and I will respond to the questions that are collecting through the presentation at the end of my presentation. All right, let's go back to the presentation. Let's talk about the pros and cons of the currently available anticoagulation agents. So Rivarox, as I mentioned, is IV only. It's a fast-acting anticoagulant, and the test for APTT is commonly used to monitor the effectiveness of that. Its disadvantages are that it's IV only, and it's really used for short periods of time. It's only used for short anticoagulation. Second agent is warfarin, the topic of our discussion today. The advantages, there's a large clinical experience, and the test called INR is used to monitor. The disadvantages, that is, it has serious adverse events. These are well known. As I talk to my physician colleagues who use warfarin extensively, they tell me that they fear warfarin, but at the same time it's a very effective drug, and that's why they use it. Let's look at clopidogrel. The advantages, it does not require INR monitoring. The disadvantages, it's not approved for orthopedic use, and there is no reversal agent. So if a patient overdoses on clopidogrel, there's no intervention or no antidote to reverse the bleeding that might occur. Prasugrel, Efficient, INR is not required. That's the advantage. The disadvantage, it's not approved for orthopedic use. There's no reversal agent. Rivaroxaban or Xarelto, INR is not required. Disadvantage, limited clinical experience, and no reversal agent, although Rivaroxaban is starting to become a significant drug used in the market, and the clinical experience with that drug is growing very rapidly. Dabigatrin advantages, it's a warfarin alternative. The disadvantages, it's not approved for orthopedic use and there is no reversal agent. Rivaroxaban is IV only. It has really limited advantages, disadvantages, it's IV only, it's not approved for orthopedic use and there is no reversal agent. So of all of these agents, Rivarox is used extensively, warfarin is used extensively, Rivaroxaban use is starting to become quite large across the United States. So we'll focus on those issues as we go through this presentation. Talking about warfarin for just a moment, it has been the standard of practice for anticoagulation for more than 50 years. It is used for prevention of stroke in patients with atrial fibrillation. It's used for prophylaxis of venous thromboembolism and pulmonary embolism in patients with prosthetic heart valves and myocardial infarction. And it's used for prevention of pulmonary embolism and deep vein thrombosis in patients undergoing orthopedic surgery or with a history of venous or arterial thromboembolism. Well, of course, let's start to thinking about why we're even talking about warfarin. How many patients are started on a new prescription of warfarin each year in the United States? Think about the answer to this one. How many patients are started on a new prescription of warfarin each year in the U.S.? The answer is 2 million. So there are 2 million new patients are started on warfarin each year. What is the standard practice today to manage warfarin therapy? So do you always use heparin first? Do you use APTT to manage it? Do you start on 5 milligrams per day? Do you use INR to monitor with the optimal range 2 to 3.5? Or do you monitor ESI and you want it to be greater than 10? What's the standard practice today for managing warfarin? The answer is you want the INR to be between 2 and 3.5. That indicates optimal anticoagulation. If the INR is above 2, it indicates that good probability of stroke prevention. And as long as the INR is less than 3.5, it indicates a high probability that you're not going to have excessive bleeding. How many times on average is a patient's warfarin dose changed in the first 3 months of therapy? Think about that question. Patient starts on warfarin. How many times is their dose changed in the first 3 months of therapy? Does a dose change occur rarely? Once or twice? 3 to 5 times? 6 to 10 times? Or more than 10 times? The answer on average is 3 to 5 times. So every new patient that starts on warfarin experiences a dose change, on average, 3 to 5 times. The likelihood that a dose change is not going to occur is rare, and there are some patients that require up to 10 different dose changes to reach steady state. As a result, there are 20 million prescriptions written per year in the U.S. The cost of warfarin adverse events is more than $2 billion per year in the U.S. I'm getting some notes here from our producer to change my audio settings a little bit. Let me look at this for just a test your audio. Just lower your mic bar. All right. Hope that's a little bit better. So, 20 million prescriptions for warfarin written every year. And the cost of warfarin adverse events, more than $2 billion per year in the United States. Very significant cost associated with warfarin use. However, as I mentioned earlier, my physician colleagues tell me that warfarin is a good drug. They use it, but they fear it because of the adverse events associated with it. So what's the average cost of hospitalization for a major warfarin-induced bleed? The photograph on this slide is of a minor bleed. That's not a bleed sufficient to suggest hospitalization. So we're talking worse than what is shown here. What's the cost of a hospitalization due to warfarin-induced bleed? On average, it's $36,000. So if you have to put a patient in the hospital, the cost is quite significant. So here's the warfarin molecule. It's a coumarin derivative. It has an isomeric carbon in it, so it has an R and S isomer. You can see the HS and HR. Let's flip to the next slide. It starts to become a little bit more clear. S-warfarin is the active form of the drug. It's approximately 5 times more active than R-warfarin. So the majority of the focus of this presentation going forward is going to be on the S-warfarin isomer. Let's consider warfarin metabolism for just a moment. The S isomer of warfarin is metabolized by cytochrome P452C9. It's metabolized to 7 and 6-hydroxywarfarin metabolites that are inactive. The R-warfarin isomer is metabolized by different enzymes, cytochrome P451A2, 3A4, and 2C19, to the 4, 7, and 6-hydroxywarfarin, and those are inactive. The rate of metabolism of our warfarin is approximately 3 times slower than the metabolism of S-warfarin. So there is a difference in terms of how the isomers are metabolized. We're going to focus on cytochrome P452C19 as the major enzyme associated with significant warfarin metabolism through the remainder of this talk. If we consider the mechanism of action of warfarin, we really want to focus on the coagulation cascade. If you take your eye down to the low part of the image, what we're interested in is the activation of factors 2, 7, 9, and 10 through the coagulation cascade. The coagulation cascade involves an enzyme called vitamin K epoxide reductase that converts vitamin K to the reduced form, and then that cycles in as a cofactor to gamma-glutamyl carboxylase and calumenin to convert inactive factor to active factors. In that cycle, then vitamin K is regenerated, and it continues through this loop process. So we're really interested in converting inactive factors 2, 7, 9, and 10 to the active factors to induce clotting. Warfarin essentially inhibits vitamin K epoxide reductase, so you do not convert vitamin K to the reduced form. So factors 2, 7, 9, and 10 remain in their inactive form, and coagulation is not taking place. So if we look at this entire picture, we're fundamentally interested in the metabolism of warfarin. So if you have active metabolism, you eliminate warfarin and reduce the anticoagulation effect. And we're interested in this enzyme vitamin K epoxide reductase. In the presence of warfarin, that enzyme is inhibited, and so you do not convert inactive to active factors, so coagulation does not occur. So now we're going to focus on the genes involved. If we think about it in the context of pharmacokinetics, cytochrome P452C9 actively metabolizes warfarin, and if there are polymorphisms in the gene coding for CYP2C9, there is decreased metabolism of warfarin. If we think about the pharmacodynamics or the mechanism of action, vitamin K epoxide reductase complex 1, often abbreviated as VKORC1. The important polymorphisms are in the promoter region. That decreases the amount of synthesis of VKORC1, resulting in decreased vitamin K regeneration. The 3 SNPs that are considered to be of most importance in clinical practice are identified in this slide. The STAR2 SNP is a conversion at the 430 position of C to T. That's a protein change of arginine to cysteine at the 144 position. When that conversion occurs, there's about a 17% decrease per allele in the enzymatic activity. The star 3 SNP is a conversion of A to C at the 1075 gene position, which converts an isoleucine to leucine, and there's about a 37% decrease in enzymatic activity per allelic change. And there's a star 6. It's a bit more rare than the star 2 and star 3, which is a deletion of adenine at 818, results in a truncation, and there's 0% activity per allele in the event that that SNP is present. There are other alleles reported with respect to warfarin. There's too little evidence to understand how you would use that information in clinical practice. So today in clinical practice, the focus is on the star 2, star 3, and star 6 allele variances. Vitamin K epoxide reductase, the key enzyme is the guanine to adenine polymorphism at position 1639 in the promoter region, which reduces transcription of vitamin K epoxide reductase. There are other SNPs, you can see them on this particular slide. The good news is that the G to A polymorphism at 1639 is highly associated with the other known SNPs, so if you monitor 1639 SNP, you get pretty much the dominant piece of information out of the genotyping that'll help you understand whether vitamin K epoxide reductase is affected or not. So the key terms to remember is CYP2C9. If you have a homozygous star 1, that individual is a rapid metabolizer, and in fact, the rapid metabolizers may require a higher dose of warfarin to achieve significant anticoagulation. So if you have a patient with star 1, if they don't receive a higher dose, their INR is going to be too low, and that does predispose them to stroke. The star 1, star 2 is the dominant, or what you'd call wild type. They're also considered to be rapid metabolizer, and they get the usual dose of 5 milligrams a day for an adult of average weight and age. Star 1, star 3 has reduced metabolism, slightly lower dose of warfarin is required. Star 2 has poor metabolism, an even lower dose, and a star 2, star 3 heterozygote individual is a very poor metabolizer, and they will need a much lower dose of warfarin to achieve optimal anticoagulation. We consider the vitamin K epoxide reductase, the GG wild type produces the amount of protein that the typical warfarin dose is adjusted for. If they have the GA SNP, they're producing less protein, and so they will require a moderate dose reduction. And if they have the AA homozygous polymorphism, they will make even less protein, and that requires an even lower warfarin dose. This was our learning experience at Mayo Clinic, and it really helped me and my physician colleagues understand how best to use warfarin genotyping. If you focus on the left side of the slide, the common wild type 2C9, star 1, and let's move over to the next one, 2C9, star 1, star 2. Those are the most common genotypes, with the vitamin K epoxide in the GG phenotype or genotype. These patients typically respond well to the typical warfarin dose of approximately 5 milligrams per day for an average adult, average weight, average age. As you move your eye to the right of this slide, you will see that the more we experience nucleotide polymorphisms, the lower the dose has to be to achieve optimal response to warfarin. And if you focus on the far right, CYP2C9 star 2 star 3 vitamin K AA, that's the most sensitive warfarin genotype. Those patients actually require about a 60 to 80% dose reduction to achieve optimal anticoagulation. So this was our learning set. We published this in Mayo Clinic Proceedings in 2009. If we just focus in on how much INR variance did we see among the different genotypes, so if we looked at the first 10 weeks of therapy, considering that the optimal INR was 2 to 3, you can see that the patients with the normal genotype star 1 star 1 GG type had a pretty typical experience of what you'd optimally want with warfarin. But as you get into the patients with the genotype that represents more and more polymorphism, they showed a lot more INR variance on average. And more importantly, if we go to this slide, this is the highest INR experienced during a 10-week cycle. You'll notice that in the first few weeks, some of these patients experienced very large transient INRs during the first few weeks that required a significant dose reduction to achieve optimal response. So the patients with the very sensitive polymorphisms, that would be star 2 or star 3 and GA or AA type, you can expect those patients will have much larger variation in INR early in their dose cycle. So let's put a question to you. What is the most sensitive warfarin genotype? Is it a star 1 star 1 GG? Is it a star 1 star 1 GA? A star 2 star 1 GG? A star 2 star 3 GG? Or a star 2 star 3 AA? What's the correct answer? I hope somebody in the audience is saying, wait a minute, that's wrong, because indeed it is wrong. 5 is the correct answer. The most sensitive warfarin genotype is CYP2C9 star 2 star 3 AA. If you ever see a patient with a star 3 star 3 AA, they're even more sensitive, but the frequency of that particular genotype is very rare. Now I'd like to transition to a more recent study, an outcome study that evaluated the clinical utility of warfarin genotyping. This was a large prospective nationwide study to evaluate the effectiveness of warfarin genotyping. The target patient was a community outpatient practice. There were comparative groups, an intervention group with warfarin genotyping and a control group with no warfarin genotyping. And the outcome was evaluated based on hospitalization rates, differentiating between all-cause hospitalization or hospitalization due to bleed or thromboembolism. And the ICD-9 codes were used as the primary indicators. This study was carried out between large medical centers and a large insurance company who had access to a number of these bits of information. The study was published by Epstein in the Journal of American College of Cardiology in 2010. So the way this study worked was that because it was run in collaboration between several medical centers and a large insurance provider, we were able to interact with pharmacies across the entire United States. So when a physician ordered a new warfarin prescription, and the patient showed up at the pharmacy would initiate contact with the patient in the study. So when the study contacted the patient, and if the patient agreed to participate, then the study contacted the provider, and if the provider was willing to participate, the study moved forward, and a home health care nurse visited the patient at home to obtain IRB informed consent, to obtain a history and including the reasons for warfarin and co-medications, and to collect a blood or a buccal sample. Once the sample was collected, it was sent to the laboratory where genotyping was performed. The report was then faxed to the provider, and the laboratory report included recommendations for dosing. The recommendations essentially were increased dose to maintain therapeutic INR, patient likely to respond to usual dose, modest decreased dose, recommended to maintain therapeutic INR, or a significant decreased dose to maintain therapeutic INR, and more frequent INR monitoring recommended. And then in a few cases where we had these very high genotypes, and there were 36 patients in this particular study with the very, very sensitive genotypes, a phone call to the provider alerted them to the fact that this patient may be very susceptible to warfarin. For inclusion in this study, the patients had to be on warfarin for at least 3 months. The patients had to be in the age range of 40 to 75. The patients were followed for 6 months, and a complete patient medical care utilization must be available. So to start with, we enrolled 1,600 patients, and by the time the study was completed, 896 patients qualified for inclusion. So we had 6 months of follow-up, and all of the medical information was available for evaluation. Patients came from across the entire United States, including Alaska and Hawaii. There's a concern about studies like this. It's called the study effect. That means if you intervene with the patient is going to be more responsive to therapy. You have to design the study so you avoid that. The criteria defined to minimize the study effect is to have minimal interaction with the participants. It's ideal to have a high recruitment rate. One uses a quasi-experimental statistical design with propensity scores identified to compare the different groups. In this particular study, the recruitment rate was 65%, and that was considered to be a very high recruitment rate for a study like this. So the belief was that the study effect had minimal effect on the outcome. The genotype distribution observed in this particular study, I'd have you focus your attention on the prevalence. Note that the warfarin sensitivity identified as being very high sensitivity, that would be the VKAA or GA type, and the CYP2C9 star 3 or star 2 type represented 2.5% of the patients. Our clinical recommendation is that these patients receive significantly decreased warfarin dose and frequent INR monitoring. Those with high warfarin sensitivity, that would be AA and star 1, star 2 type, 4%. Those with moderate sensitivity, star 1, star 1, and so forth, 25% of the population. Those with what we defined as mid warfarin sensitivity, they were all of the VKGG type with CYP2C9 star 1 over star 2, 12%. The normal genotype, which is GA and star 1, star 1, 29% of the population. And actually less than normal warfarin sensitivity, GG star 1, star 1 genotype, 25% of the population. We point out to you is that a significant fraction of this population was of the less than normal warfarin sensitivity GG star 1, star 1 type. These patients require a higher warfarin dose. This was a surprising outcome of this particular study because this fraction of the population in this particular genotype group was higher than reported by others. The study involved intervention groups and historical controls as well as external concurrent controls. So we basically controlled for change in practice from the year before to the year of the study, and we monitored patients who were received warfarin genotype information and compared them against patients who had not received it. I'm going to flip through this fairly quickly. This was the outcome of the study for hospitalization for any cause. So if you consider patients who are started on warfarin within the first 6 months of therapy, on average, at the end of that duration, 23% of them had a hospitalization experience. For those patients that were treated with genotyping, 15% of them had a hospitalization experience. So now we're talking any cause. Obviously, patients who are going on warfarin are sick patients. So there's a variety of reasons why they would go in the hospital, but certainly from the standpoint of management, the patients who were treated with warfarin genotyping had a lower hospitalization rate by a factor of about 35%. It's a hazards ratio of 0.67. If we consider hospitalization rates only for bleed or thromboembolism, at the end of 6 months, the patients who were treated without warfarin genotyping, 6% hospitalization rate. So 6% of the patients ended up in the hospital. That number is consistent with many other reports for the hospitalization rate for patients on warfarin. For those patients that were treated with warfarin sensitivity genotype, the hospitalization rate was in the ballpark of 3%. So there was about a 50% reduction in hospitalization rate for bleed or thromboembolism based on whether a patient was treated with or without warfarin genotyping. So a fairly significant hazards ratio. You have about twice the hazard of becoming hospitalized during the first 6 months following warfarin therapy if you're treated without warfarin genotyping. The key findings: patients treated with warfarin sensitivity genotype experienced 35% reduction in all-cause hospitalization, 43% reduction in major bleed or stroke. And surprising to the study was that the impact was greater on the incidence of stroke. And they attribute that to the fact that the number of patients that had the less than normal sensitivity to warfarin, at 25% who needed a higher dose, that particular group was significantly impacted. If we consider the national U.S. cost impact over the 6-month monitoring period, all-cause patient costs were $4,127 for those that were genotyped versus $5,040 for non-genotype controls. That includes an estimated cost of $300 for the genotyping, so that was factored into that cost. So the patients who were genotyped had an average saving of about $253 per patient. If we were to translate that to 2 million patients started on warfarin annually in the U.S. and warfarin sensitivity genotyping were implemented, that would decrease the cost of care by $500 million in the United States. Let me come back and reemphasize that. If warfarin sensitivity genotyping were implemented across the board, the cost decrease to the entire U.S. population would be in the ballpark of $500 million. Now let's translate these findings to practice. One of the early studies that started to demonstrate the value of warfarin genotyping was carried out in Israel, In this particular case, they demonstrated that when patients were managed with the genotype information, the time to steady state INR decreased by 50%. So the time to steady state INR for patients managed with genotyping occurred in 5 to 7 days, whereas those that were managed without genotyping, the average time to stable INR was in the ballpark of 10 to 15 days. And if you're putting a patient on warfarin, you're putting them on warfarin to avoid formation of clots that will lead to a stroke. If you can get them to stable INR fast, there is a benefit. Hazard ratio here was almost 3 to 1, so the benefit to those patients that were genotyped and treated appropriately was a threefold benefit in reaching steady state INR. I'd call your attention to work done by Dr. Brian Gage at Washington University. Dr. Gage has created a very nice website that is available, and for those of you who are interested in this topic, I'd encourage you to visit that website, www.warfarindosing.org. Dr. Gage offers if you enter patient demographics, that includes a lot of information about important things like race, age, smoking status, whether patients are on amiodarone, whether they're on a statin. This particular website will project the optimal warfarin dose for that patient. So let's come back and talk about incidence. What is the incidence of warfarin sensitivity? The less sensitive genotype is approximately 25% of the patient population. They need a higher warfarin dose. The typical warfarin sensitivity genotype, that's the star 1 GA, 29% of the population, they will respond very well to the typical warfarin dose. Mild sensitivity, 12%, and we get down to very sensitive and extreme sensitivity for 2.6%. Point out here that the 33% of the population requires a lower warfarin dose. Point out particularly that the less sensitive 2C9 star 1 GG genotype is very common among those of African origin, and that might explain why more patients of African origin have stroke on warfarin than compared to Caucasians. Asians, on the other hand, have the 2C9 star 1 VKAA type more common than in Caucasians. The extremely sensitive genotype, 2.5% of the population. That means 2 to 3 patients out of 100 started on warfarin are going to require a very, very low dose. Don't you think it would be advantageous to know that before you start managing this patient rather than 10 weeks after? Come back to the Mayo experience. I showed you this slide earlier, and I'm going to move on now to the FDA warning relabel that occurred in February 2010. I'm going to flip back and forth between these two slides. They are virtually identical. So the recommendations for dosing put out by the FDA in 2010 are essentially identical to the experience that we had at Mayo. Lab recommendations with regard to what to do with the specific genotypes. If you have the less sensitive genotype, it is based on the usual dose adjusted for age, weight, and co-medications. Add 20% to that dose. The typical genotype, the star 1 GA, receives the usual dose. Star 1 star 2 GG type, about a 10% dose reduction. The various CYP2C9 variants with various VK variants, 30% dose reduction. As we get down into the very sensitive genotypes, up to 60% dose reduction, and the recommendation that much more frequent INR monitoring is indicated. Okay, I need to make a note to the producer of this for just a second. Tracy, my phone just went offline. Hope you can still hear me. Let's talk about benefit to practice. So in a typical practice, the provider would write a prescription. The patient provides buccal sample and a warfarin first dose administered that evening. Typically, you'd give the patient the usual dose if it's an adult of average size and age, 5 milligrams per day. The warfarin genotype result comes back the next day, and then a dose adjustment is made if needed. Under this type of practice condition, patients achieve stable dose in INR faster. They require fewer dose changes and have fewer INR outliers. Those are significant benefits to the practice. Patient benefit? Well, the patient experiences fewer adverse events. The patient requires fewer dose changes, and the patient has a bit less expense. If we consider the average prescription cost to a patient, this is not the total cost, this is the cost to the patient. For warfarin is approximately $9 a month. For Plavix, it's $200 a month. For Xarelto, it's $250 a month on average. So the out-of-pocket expense to the patient is significantly less by warfarin prescription guided by warfarin genotype evaluation. A couple of cautions. It's interesting how our government operates. The Food and Drug Administration recommends but does not require warfarin sensitivity genotyping. The Center for Medicare Services will not reimburse for warfarin sensitivity genotyping. The American College of Chest Physician Guidelines, published in 2009, explicitly did not recommend warfarin sensitivity genotyping. However, those guidelines that were updated in 2012 explain warfarin sensitivity genotyping but do not make recommendations regarding their use. So at this stage in the sequence of events, warfarin sensitivity genotyping is not considered to be the standard of practice. If you have a patient who is on Medicare, CMS will not reimburse for the testing, so the patient will experience about a $300 charge. And yet the FDA recommends warfarin sensitivity genotyping. A bit of a conundrum, and I'll leave you to decide what's the best thing to do for your specific patients. Let's end this with a short quiz again. What's the standard of practice today to manage warfarin therapy? I hope you all got this right, 2 to 3 INR. Which is the most sensitive warfarin genotype? CYP2C9*2*3 VKAA. If you ever saw a patient with CYP2C9*3*3 VKAA, that patient would be even more sensitive, but the incidence of that is about 1 in 10,000 or so. What is the benefit to practice? Will providers know which patients will require more management than typical? With experience, will providers know which patients will require less management? Will patients achieve stable dose in INR faster with fewer dose changes in INR outliers? Will patients experience fewer adverse events? Or all of the above? What is the correct answer? Well, all of the above should be expected. At this point, I'll turn to ask if there are any questions. I don't see my Q&A button flashing, so far there haven't been any questions submitted. I'll thank you for your interest and direct you to website. So in order to obtain the continuing education credits, go to www.bioconferencelive.com/CME-CE. I still don't see any questions showing up, so there is a chat room, and I will be available on the chat room for a short period of time. If any of you have any individual questions you'd like to ask, I will be at the chat room. So I thank you for your attention and wish you a good day. Thank you. Okay, we're still on air, and I have a first question. So, Emilio from the University of Genova says the trial showed a major impact on stroke. This implies that it is a matter of resistance rather than sensitivity. Anecdotally, I had the impression that we have sort of reluctance to increase dosage of warfarin. Did you? Well, in answer to that question, it's not an issue of resistance. It's that the metabolism of warfarin occurs faster than normal, and the amount of protein, of VKORC1, available to activate clotting factors is increased. So the patients need a larger dose of warfarin to maintain optimal anticoagulation. Now, would you call that resistance? I don't think that's resistance. It just means that pharmacokinetically and pharmacodynamically the patients are more effective coagulators, so you need more warfarin to achieve optimal anticoagulation. There's a second question here. What is meant by recruitment rate? The recruitment rate is if you approach a patient and ask if they will be involved in the study, and they decline, then they're not involved in the study. So if you ask 1,600 people to be involved in a study and 1,200 of them say, yes, I will be involved in the study, that's a recruitment rate of approximately 65%. So recruitment is important in the sense that the patients are willing to participate. And in this particular study, the patients had to be willing to participate and the physicians had to be willing to participate. So it took two individuals to achieve a recruitment into the study. High recruitment rate is considered to be better because statistically it means that your data are going to be more representative of the entire population. So Tracy, I'm not seeing any more questions, so let's end the broadcast. Thank you all very much.